Appreciate it. Yeah, I was a drunken expat at a girly bar on the left, so that's my claim to fame. Thank you so much. I want to thank the organizing committee for inviting me for this presentation. I want to thank all of you for your attention. I want to thank some of the other presenters before me. I'll disagree with Reverend Long, though I'll never be the smarter person in my marriage. So what I wanted to do is talk a little bit about our programs that we're implementing in Indonesia, how they relate to the Sustainable Development Goals, and some of the types of things that we do in this context of how we together can create a better world, and with the idea that the different skill sets that might be involved with implementing these kinds of programs. So Sustainable Development Goals in Indonesia. One of the things that's been really interesting is over the last year, we've seen from the high government level, the Minister of Health and the staff under them, they use the Sustainable Development Goals to orient their national plans. And so that's something that's very exciting, because if you look at all of these goals and the sub-goals within them, they are these tremendously aspirational goals. And they ask, well, what kind of world do you want to see by 2030? If we get to all of these different goals, then we're pretty much there. And so I think that that's really exciting to see that acknowledgement from the government and the government using these. And I think that that's happening in quite a few countries around the world. So one of the programs that we work in is related to the Zero Hunger goal. And so there's these sub-goals that are within there. There are certain indicators that are within each one of these goals. And so, so for example, one of the sub-goals is ensuring access by all people to safe and nutritious sufficient foods all year round. The next one is reduce stunting, which is a severe form of malnutrition. Then you can have double the agriculture productivity and income of smallholder farmers. And so Helen Keller International, we have a program that's associated with all of these little sub-goals, where what we try and do is develop a program that fits under each of these categories and that can hopefully improve the overall nutritional status. So just to give you an idea, in Indonesia, more than 1 in 3 children have the severe form of malnutrition called stunting. And that's about almost 10 million children under 5 are severely malnourished. And this can have a lifelong effect. It affects your brain development, it affects your height, it affects, it has these tremendous health implications that extend well on. And it's pretty much due to a diverse diet, or a lack of a diverse diet. So for example, in one of the areas that we work in, and I'll show some pictures, the families, all they eat is corn for breakfast, lunch, and dinner, or rice for breakfast, lunch, and dinner, with no greens, no tomatoes, no carrots, no vegetables with color in there, no animal sources of protein. And by just having that diet, along with some other things, that can have a lifelong impact, as I was telling you. And what they've said is that they have, I don't know if any of you have heard of the first 1,000 days, but those are the 9 months of a woman's pregnancy and the first 2 years of a child's life. That's could be the most critical time for any nutrition intervention. And if you don't target at that point, there's almost not much you can do beyond that in terms of catching up. And so that's where it becomes very critical about developing programs that can address malnutrition at those times. So we have this program called Homestead Food Production, where what we do is we train households primarily headed by women to grow micronutrient-rich foods like vegetables and fruit crops, small animals and poultry, in the areas around their house, so that they can use that and incorporate that into their diet. So you can see, like, for example, this is one of the areas in the island of West Timor in Indonesia. You'll see all of these tremendous stalks of corn, but what we've said is, okay, clear out some of the land right next to your house and use that to plant a home garden with these micronutrient-rich vegetables. And so that within about a year, when we provide the agriculture training, when we provide some of the agriculture inputs like seeds, you'll start to see the families put together little plots of land. And it doesn't take much land. We're talking, a half to a third of the size of this room. And they're able to grow a diverse set of crops, and we're able to provide some training to say, okay, during these months grow these crops, during these months grow some other crops, you know, how to do organic fertilizer. And we teach them to use seeds that can replenish year after year rather than those that you have to completely rely on some supplier from the very beginning. Did I break this? Oops. And I mean, you can start to see, within 6 months, you can start to see the families grow some of these nutritious crops, green leafy vegetables, vegetables with orange and yellow in them, and start to incorporate that into their diet. And one of the things that we do with our program, it's not just grow these vegetables, but we explain the nutritional benefits of this, and hopefully in an easy to understand way for those communities. And so you can see here that, that we'll have some people that are leaders within the community, and that they'll create nurseries and they'll grow the crops within. They'll even start to share it out with other members of the community. And so then that you start to see this spread beyond. This particular program, we've been implementing it since the 1980s, 1990s, and it's in Asia alone, I think that it's reached about 1 million households. And it's one of those things that sustains. We have a targeted period of about 3 to 4 years where we work with the community before we try and shift to another place. And then you'll start to see those communities take on these lessons, grow these vegetables, keep growing them even well after we leave. And I mean, the ultimate end goal is to have households introduce these diverse diets. So you can see that, previously you see the corn, kind of the corn soup that they're eating, but now what we've done is we've worked with these households to incorporate green leafy vegetables. And so this is immediately after, I guess, what we have like our own master chef, West Timor. And so we have a cooking demonstration and where people will come in and they'll bring some of their own vegetables. We'll teach them how to cook something nutritious. And this kid in particular, once we started introducing green leafy vegetables into his diet, he couldn't stop eating, and the other kids would just stare at him because he'd swallow it down. So, it's one of those things that it's something relatively simple but can have a really major impact. And hopefully this is a family that can continue it on through the productive years, and it can be a self-sustaining way of hopefully reducing out malnutrition. So another one of our programs is associated with good health and well-being. And so, they have these sub-goals under that over here under Sustainable Development Goal number 3, that it's about reducing by 1/3 premature mortality from non-communicable diseases through prevention and treatment, and then strengthen the capacity in all countries for early warning, risk reduction, and management of national and global health risks. In Indonesia, like many countries, there's all of a sudden a lot more KFCs, McDonald's, Burger Kings, Wendy's, and so diabetes is on the rise. I think somewhere between 5 to 7% of the adult population in Indonesia has diabetes, and of that, there's an eye condition called diabetic retinopathy. And what that means is that if you have diabetes for about 10 years, you have a 1 in 3 chance of developing diabetic retinopathy, which will lead you to going blind. So in Indonesia, population 250 million people, it could be that, there's 5 to 6 million adults with diabetes in Indonesia. They're developing it at an earlier age. We could have about 2 million people go blind as a result of this disease. And so one of the things that we're doing at Helen Keller International is trying to figure out a way to identify very early potential causes for diabetic retinopathy and get these people to treatment as quickly as possible. This is just a normal retina. So what you have to do is, in order to identify diabetic retinopathy, it's not something you can kind of see. And by the time you start to lose your sight, it's too late to actually do anything about it. So what you have to do is you have to come in. This is a normal retina. You have to go through a screening process where they'll look at the back of your eye. And then, over here you'll start to see the diabetic retinopathy, and you'll start to see these kind of, the blood vessels burst. And that's what's causing the blindness. So the idea is that you want to do some kind of laser treatment before it gets to this point. And it's actually pretty cool. Like, it kind of zaps and you see these little grids and stuff like that, and it takes care of it. But the point is that there's a very easy fix if you're able to screen people with diabetes on an annual basis, which is, I think, what happens here in Australia. Certainly in the US and the UK, it's part of the annual package of screening. You identify people as quickly as possible. If they have signs of blood vessels bursting, you get them access to laser treatment, and then and then that can prevent the blindness. Here again, how do we work together? What we're doing is we're working with tertiary hospitals, provincial level, state level hospitals, to develop screening programs. They didn't have it as a routine part of care for people with diabetes. People with diabetes went over here, people with eye problems came over here, and it didn't really sort of overlap in a structured way. So how will we work together? We've been working together with the Indonesian government, with hospitals, with health centers, to screen people that have diabetes for diabetic retinopathy on a routine basis, with the idea that we can find this early enough. And so this is where, people with varying degrees of skill sets, there's people that can develop applications that can do automatic detection of diabetic retinopathy if you have a retina screen. So if you have anybody with sort of a techie background, that's an area where we could certainly use some help in kind of thinking it through. Referral systems, making sure that, we track people either through text messages or, other electronic communication as they go through the different levels of the system. That's another area. Making sure that people have diverse diets, better control of their diabetes. So, these are all different things that can contribute towards reducing this burden of diabetic retinopathy. And so that's an area that we've been working. And so this is just a picture of a program where what we found is that not a whole lot of people with diabetes were making it into the hospital to be screened. And so then what we said is, okay, well, let's take this camera, which is, a relatively large piece of equipment, and let's take that out into the primary health centers. And we were able to expand out screening in that way. And by presenting this data, what's been really interesting is that the government's kind of taken it up and say, well, this is where we've got to go. If you at the hospital in 1 year, you might screen, 300 or 400 people and for diabetic retinopathy. You go out to the primary health centers and you might screen, tens of thousands. And so then the question is, you have to build the infrastructure, you have to cart this camera around all over the place. But those are the kinds of things that we as a non-governmental organization are there for, to help them think through, and then we hope that this gets adopted into national policy. And so then the last thing, which I think the commercial that we saw right before sort of took a little bit of it, is quality education. And this has been a really exciting area for Helen Keller International, in that we've been working on education for children with disabilities since 2003, but actually it's sort of part of the history of the organization. The commercial said, 90% of children with disabilities in developing countries don't have access to education. They don't go to school. They're not counted by the census. And so what we've been doing is we've been working with the government to try and develop a system so that we can get children with disabilities into your neighborhood school that's just down the road, as opposed to some special school that might be, miles away and just generally not accessible. And so here, you have these two sub-goals under the quality education goal over there. And so we've been doing work and trying to operationalize against these two indicators. And so here, in Indonesia, again, as many as 3 million children have a moderate to severe disability. Most of them don't have access to education, and they have very limited access or opportunities to reach their full potential. And so that's something that we've been working on, is to work with the Indonesian government, to work with the Ministry of Education, to work with schools so that they develop the policies, that they have those kids come into school. And we're not talking about anything terribly high tech. Part of it is just training teachers to know it's all right if a kid's kind of hyper and running around all over the place, You just have to spend a little bit of extra time. Or, some kids, they might not understand the lesson plan right away. You might have to spend a little bit of extra time with them. You might need to sit with them. I mean, so it's small practical steps like that that can help lead to educating this child within an inclusive setting with all of the other children in the neighborhood. And so, you know, this is an example. So this is a student who, prior to working with this school, he wasn't able to go to school, but now he goes. Now his teacher knows, okay, well, I might need to spend an extra 15, 20, 30 minutes with this child after school to kind of go over these lessons and make sure that they absorb all of the information that's in the class. This is another student who he gets support from an auxiliary teacher who comes into the classroom once or twice a week and sort of helps the child focus in on what the lessons are. And these are just small practical steps that help increase the accessibility to education. And then also we've helped to develop a program where, you know, you get children to exercise and get participate in physical education, whereas before, you know, they wouldn't get a chance to sort of they wouldn't get a chance to participate, but now they can, and they can play sports, and that's a great way to build the community. This is the last slide, but what I just wanted to share is that just by giving a very, very quick snapshot of what we do, it's maybe a small description of the diverse skill sets that are needed in terms of providing these sorts of programs. And if we talk about, you know, how all of us will work together, I think all of you have these tremendous skill sets and things that you can contribute in terms of helping out these different programs. And I'd certainly be happy to hear from any of you afterwards. I have my email address up here. You know, I mean, please get in touch. I mean, if you have any ideas, if you have any interest in working in the sector, if there are things that out of what I've spoken about here that you're like, oh, well, you need to know about this, please let me know. And I just want to leave you with one quote from Helen Keller, which I think is appropriate to today's session. It's that alone we can do so little, together we can do so much. Thank you.